Hello, my name is Zara Khan, and I'm going to be talking to you about atopic dermatitis. Before we get into the oral presentation about atopic dermatitis, I'm going to talk a little bit about what the condition is and who it primarily affects. So, atopic dermatitis is a chronic relapsing inflammatory skin condition that affects about 2 to 10% of adults and 10 to 20% of children. And children who have this condition tend to grow out of it or have a lesser form of it as they get older. But people who have their first flare up as an adult will likely have to deal with periodic flare ups throughout their adulthood. And there is no cure for atopic dermatitis, it's more finding how to stop the cycle and reduce the amount of flare ups that you have. So there are three things that cause atopic dermatitis in our bodies, and we're going to talk a little bit about each of those. So the first thing is that it is an impaired skin barrier dysfunction. Two, it is immune dysregulation, and three, it's pruritus, which is just a fancy word for itching. So let's start by talking about the impaired skin barrier dysfunction. So basically, our body has this protein that is called filaggrin that helps maintain our skin barrier. And when filaggrin is deficient, the skin loses water more easily. So it becomes dry, and that allows allergens and irritants to penetrate and trigger inflammation in our body. So the immune dysregulation is the second thing, and that's primarily driven by our type 2 helper T cells with the help of cytokines. And the specific cytokines that are involved in atopic dermatitis are IL-4, IL-13, and IL-31. IL-4 and IL-13, these are going to worsen the barrier defect that we just talked about, so it's going to promote more inflammation, while IL-31 is the main cytokine that is responsible for the itching. So this leads to what is known as, in atopic dermatitis, the itch-scratch cycle, where scratching causes more skin damage and even more inflammation, which leads to more itching, and so on and so forth. And patients with atopic dermatitis are gonna be more prone because of this to colonize things like Staph aureus, which can cause secondary skin infections. So let's move on to talking about our specific case. So we have a 50-year-old woman who presents in the office today with a history of eczema involving her bilateral outer axillary regions, which she's having a flare up of today. Shows she has reported intermittent episodes of redness, drying, and itching over several months. The rash was localized to the outer axillary skin without involving the skin fold, so the inner part. She denies any fever, drainage, pain, use soaps, detergents, or any of this type of rash in other areas of her body. And she has experienced similar flares in the past that have improved with topical steroids, but this has recurred periodically, and she would like a different treatment, a different approach for her condition. So we are going to do a physical exam on her first. So upon physical examination, she has no acute distress. She appears well. The examination of the bilateral outer axillary region is going to reveal a well-demarcated erythematous patch with mild scaling and xerosis. And xerosis just means like those itchy scratches. There was no purulent drainage, crusting, vesicles, fluctuants, or any signs of secondary bacterial infection, and the axillary folds were spared. So again, the inside part of the underarm. The remainder of the skin examination on the rest of her body was unremarkable. So based on this physical examination, me as the provider is going to make a clinical assessment. So based on her physical exams, the symptoms are more consistent with a mild localized atopic dermatitis. If we were supposed to say, give it a scale of, mild, moderate to severe, this is a more mild atopic dermatitis confined to one area. Some differentials that would come to mind would be allergic contact dermatitis, irritant contact dermatitis, and inverse psoriasis, or superficial fungal infections, and candidal intertrigo. So allergic contact dermatitis, her history didn't really support any contact with any allergen, irritant contact dermatitis. She didn't use any new products. Inverse psoriasis, sometimes chronic psoriasis can present physically, especially chronic psoriasis, as eczema as well. Superficial fungal infection, we didn't have any purulent drainage, like we said. Candidal intertrigo wouldn't be the case here because that more affects the skin folds and is caused by the rubbing of skin folds, and it appears more like red and not more so scaly. So now that we've kind of figured out what our diagnosis is, we're going to talk a little bit about the diagnostic plan. So atopic dermatitis is a primarily clinical diagnosis. There's no laboratory testing or biopsy that's indicated when a person has this condition. We just look at it, if it's chronic, if it's relapsing, if it's in the areas that atopic dermatitis presents. So on the insides of our knees, our elbows, the outer parts of the axilla, like we see in this patient. You can do a potassium hydroxide preparation or like patch testing or a skin biopsy if it doesn't present like eczema, or if you, for example, thought it was eczema, tried to treat it, and it didn't get better, so it proved that it wasn't eczema. Any atypical presentation would require you to do some further workup. But if you're sure that it's eczema, you don't have any formal way to diagnose it. So after you present these diagnostic findings to the patient, explain what they have, you're going to come up with a treatment plan. So the patient was prescribed a topical steroid in the past and started using it again when they had this flare up, and has been using it for the past week, and it didn't help. So the next step would be to use a non-steroidal. So there's a couple of reasons why we would go that way. One, they tried a topical steroid and it's not working. Maybe their skin has gotten used to using a topical steroid. Two, topical steroids you can only use for about 2 weeks at a time, every other day. That's the max dose. So she's already used it for a week and hasn't seen improvement, so she only has a week more of using it. Whereas when you prescribe non-steroids, you can use them for longer periods of time and use them more frequently. Another good reason for using non-steroids is that if we prescribe her another topical steroid, that can cause skin atrophy, which is just skin thinning, and the skin on the outer parts of our axillary region is primarily more sensitive compared to other skin areas, so they're more prone to atrophying compared to, more coarse areas, like for example if you had a patch on the skin on your leg. So the non-steroidal that I'm going to prescribe her is tacrolimus 0.1 ointment. So I'm going to tell her how to use it. You're going to apply it twice daily to the affected areas, and you can use this until the flare is improved. So it doesn't have to be up to 2 weeks like a steroid. And then on top of this, the patient is also recommended to use a fragrance-free moisturizer that will also help restore the skin barrier and decrease the xerosis, which is the scratchy itchiness. So after the patient has understood what we're going to prescribe, how to use it, what other over-the-counter things they should use, like the moisturizer, we're going to inform them to follow up with us. So you're going to follow up with us in about 6 to 8 weeks. That's if you're not having any, symptoms on the tacrolimus. It's working fine. You're noticing a difference. You're not having any symptom worsening, signs of infection, or if the rash failed to improve, you can obviously follow up much quicker. But if you are doing fine on the medication, you should see an optimal results in the flare-up in 6 to 8 weeks. And yep, that is it. I hope you enjoyed and learned a little bit more about atopic dermatitis through this case presentation.